Floatron boots and compression stockings are placed before surgery is started. Access is obtained under ultrasound guidance using either the standard Seldinger technique or cut down. A guide wire is advanced through the diseased segment of the vein. The occlusion must be able to be traversed by a guide wire to be able to properly perform the procedure. A venogram is performed to establish a roadmap for treatment. Before proceeding, the wire is advanced into the IVC. To ensure that the wire has not inadvertently entered the spinal collaterals, its position is confirmed by a flash venogram in both the AP and lateral projections. A 9 French sheath is inserted in order to introduce the IVUS catheter and stent delivery system. The IVUS is inserted and positioned at the uppermost point of the disease. An IVUS recording is taken by moving the IVUS catheter peripherally, viewing the full extent of the disease. The stenosis is evaluated and rationale for stenting confirmed. The IVUS catheter is advanced centrally to a normal vein segment. Assess the diameter of the normal vein and take the average of the minimum and maximum diameter. Select a stent size at least 2 mm larger than the surrounding normal vein. In this case, a 16 mm diameter stent was chosen, as the average of the minimum and maximum diameters was 13 mm. Pre-dilatation with a high-pressure, non-compliant balloon catheter is performed prior to stenting. The entire diseased segment of the vein is dilated. Pre-dilation can be performed directly with the final size balloon. Once the balloon reaches full dilation, the pressure gauge demonstrates a gradual reduction in pressure, indicating the fibrotic tissue has been disrupted. IVUS was used to determine the proper central stent location and length required. It is recommended to start the stent at least 5 mm central to the lesion. The stent system should be at least 1 cm longer than the lesion to allow for a 5 mm extension both peripherally and centrally. The lesion length can be assessed using the markings on the IVUS catheter. This case will require 3 stents to adequately cover the lesion. Other patients may require more or fewer stents to adequately cover their lesions. A 120 mm length stent was chosen for the first stent. The stent system is prepared, flushed with heparinized saline and inserted through the 9 French sheath. Advance the delivery system until the distal end of the stent extends approximately 5 mm beyond the end of the lesion. The radio-opaque marker approximates the central landing point of the deployed stent. Loosen the rotating hemostasis valve by rotating it counterclockwise to release the stent system. Secure the inner shaft hub with one hand and retract the outer shaft by gradually pulling the Y connector towards the inner shaft hub. As deployment begins, some resistance will be felt. With the inner shaft hub secured, continue to deploy. The resistance will be reduced as deployment continues. As the stent opens, a martini glass shape is observed. At this point, the stent can be repositioned. As deployment continues, a wine glass shape is observed, and you are committed to this position. It is important to note that the VICI venous stent cannot be recaptured at any point in the procedure. and do not push the inner shaft hub forward, as this could result in suboptimal location or failure to release the stent. The stent system foreshortens by approximately 10 to 20% during deployment as compared to the stent length when restrained in the delivery sheath. The IVUS catheter is reintroduced to measure the position and length for the next stent. It is important to have a minimum of 1 centimetre of stent overlap when more than one stent is required. In this case, there is 15 centimetres of residual disease left, and a further 2 stents will be required. The second stent is a 16mm by 120mm stent. The second stent is advanced over the guide wire and into the sheath introducer until the central end of the stent extends approximately 2 centimetres past the peripheral end of the first stent. The second stent is deployed the same way as the first stent. Positioning of the final stent is the crucial step of the procedure, as preservation of the profunda and femoral vein is essential to maintain stent patency. The tip of the IVUS catheter is placed at the confluence of the profunda and femoral vein. The IVUS is then advanced slowly until it reaches the second stent. 1, 2, 3, 4, 5. In this case, at 5 centimetres, we are now inside the stent with just over 1 centimetre of overlap. There should be a minimum of 1 centimetre overlap, which would result in the need for a 60mm stent. Please note that the last stent can be overlapped as much as needed in order to get the proper peripheral landing zone. The third stent system is inserted for deployment. The stent will be positioned around the level of the 54 centimetre marker on the screen as previously determined. The peripheral end of the undeployed stent is well below the desired landing zone, but this is intentional. As the stent deploys, the peripheral end of the stent foreshortens. This is why an exact calculation of where to land the central end of the stent is made in advance. Once the procedure is completed, the IVUS is used to check the full stent system, and then the stent is post-dilated.
Record, so if you press record on the IVUS there, will record this pullback through the whole stent system, post-deployment of all of the stents, and then we're going to post-dilate the whole stent system.
The entire length of the treated area is post-dilated from central end to peripheral end. Final IVUS is performed to confirm that the stents have completely expanded and the position of the peripheral end of the last stent is at the confluence of the profunda and femoral veins, and the vessels have not been blocked off or jailed. A final venogram is performed to confirm flow and abolition of the collateral vessels. The sheaths are removed and manual pressure is applied. The compression stockings are rolled up over the incision site.